pectoralis minor muscle. This is the pectoralis minor muscle right here, and you can see right here the tendon of that pectoralis minor muscle and the brachial plexus passing under it. This is another one of these anatomical drawings that is incorrect in that it shows the subclavian artery passing between the two muscles. It may be that they're not really intentionally doing that. They may have tried to just show that it was there, and it may come down below where the scalenes attach. In any case, it won't affect the pulses if the scalene muscles are tight. And usually the first area that is affected is the ulnar distribution, and meaning the fourth and fifth finger, but the entire palm can be numb or have tingling from a compression of this tight muscle. And here this drawing shows it even more incorrect in that the artery is drawn coming through between these anterior middle scalene muscles. And you can see here what becomes the ulnar nerve. This is not actually the ulnar nerve. That doesn't become the ulnar nerve till probably halfway down the humerus. These are the so-called cords of the brachial plexus, and then they become the individual nerves below the area of the biceps muscle. These are just the distributions of the scalene muscle trigger points that will show up in these places if the anterior middle scalene muscles are irritated. Okay, now the piriformis syndrome is a relatively common problem and will often present with a patient complaining of symptoms which sound like sciatica and may in fact be a true sciatica. The primary muscle involved is the piriformis muscle, which is the major external rotator of the femur. The sciatic nerve runs either above, below, or through this muscle. Their primary symptom is sciatica, which is sort of this deep, dull pain going down the back of their leg. They may say that their leg feels very heavy. There's numbness and or tingling in the leg. That can be either patchy or complete in terms of dermatomes. And the straight leg raising test can be positive. Now, this is an important area because most people misinterpret the straight leg raising test. The straight leg raising test is positive only if numbness or tingling or severe pain go below the knee. If it doesn't go below the knee, it's not positive. And that's true whether you're evaluating a patient for a disc or for sciatica caused by the piriformis syndrome. And it's important to differentiate between a trigger point and its referred pain in the piriformis muscle versus the true sciatica. And I put in parentheses the knee because that is the basic way to differentiate it. If you have, and this will be in one of the pictures that we'll show in a few minutes, if you have just the trigger point in the piriformis muscle and it is causing symptoms in the reference zones down the back of the leg, the patient will complain of symptoms in the thigh, in the calf, and at the heel, and perhaps into the arch of the foot. It skips the knee if it's purely myofascial reference pain. If the sciatic nerve is irritated and gets involved directly, the patient will say that their knee is included in the symptoms. And that's a really important point to remember and makes it easy to differentiate between the two, which is kind of important. I can show you here the piriformis muscle, which attaches onto the parts of the sacrum and the greater part of the greater trochanter of the femur. And there are two trigger points, one that is just below the greater trochanter, you'll find it there, and the other one on the other end. When you inactivate this one, you're often going to be also finding that you may see a twitch response going in this direction here, if you can see my arrow pointing, and that is because the gluteus maximus lies on top of this, and there's often a gluteus maximus trigger point right there, so you may in fact be palpating two distinct trigger points in two layers of the musculature. You can see the piriformis here, the sciatic nerve here, coming through the sciatic notch, and that nerve can either be below here, it can come out above the piriformis, and in some rare instances it actually comes through the piriformis. So when this piriformis muscle gets very tight, if it's going through it, it's much more likely to cause a sciatic problem. Okay, now we'll go next to another seemingly apparently increasing problem. I'm seeing more and more of these patients where they're complaining of pudendal neuropathy. And these patients, more females than males, but there are males involved at times. There can be entrapment of the pudendal nerve by the piriformis muscle, the obturator internus, or the gemelli muscles below the piriformis, which you'll see in another diagram. It can be also from scarring from pudendal blocks. In women who have had pudendal blocks, there's almost always some bleeding, and that the body resolves as scar tissue, and if that involves the pudendal nerve, you're going to have complaints of pudendal neuropathy later in life at some point. I pushed this a little bit too far, I'm sorry. The primary symptoms you're going to see with pudendal neuropathy is you're going to see vulvar pain or vulvodynia. You may see rectal pain, which can be burning and almost make defecation impossible. You'll see vaginal pain, which makes intercourse almost impossible. Men frequently have penile pain. I've treated a male patient who literally had to wrap his penis in lidoderm patches in order to put on a pair of underwear. His pain was so bad. What's amazing is that he's one of my first cures for this problem. And these patients often have gluteal and low back pain as well as pelvic pain. In the first group, where they're clearly myofascial components, and they're probably the only components, just use the low-power laser to inactivate the trigger points. In group 2, where scar tissue is a problem, you can try to treat both the nerve and the scar tissue first with a low-power laser. If this is inadequate, you may need to use microcurrent, which also will effectively treat scar tissue. Group 3, where you have these extreme athletes, they're mostly young females who overdo activity and have overgrowth of the ligaments that impinge on the pudendal nerve. This is the only group with any reasonable results with surgery. They are probably 80% improvement or resolution with surgery. The other first two groups are less than 10%. And you can see the obturator internus here. If that's part of the entrapment, you'll see severe rectal pain, and the pudendal nerve is coming. The scar that they make to move it, to transpose it away from those ligaments in that third group is usually just like this. It's a scar that goes from medial to lateral around this canal where the pudendal nerve follows and dives into the front here. Now we'll move on to the entrapment of the common peroneal nerve. This is more often than not found in athletes and usually stumps the orthopedic surgeons who are the physicians for these athletic teams. The entrapment of one or more of the branches of the common peroneal nerve are primarily the peroneus longus muscle, occasionally the peroneus brevis, and often the tibialis posterior contributes to this. And you can see in the diagram here, the peroneus longus muscle comes along here, and the common peroneal nerve comes right behind this muscle and can be entrapped by a tight peroneus longus or the peroneus brevis, which can tighten this whole band here. The peroneus tertius muscle in the front gives you this type of pain. The peroneus brevis will give you this type of pain, and the peroneus longus can give you pain down the side here onto the top and maybe onto the top of the foot. The real problem here is you may get patches of numbness along the lateral portion of the lower leg, and the orthopedic surgeons are stumped. They don't know what is causing it. What is causing it is a trigger point here, and if you were injecting this, you'd have to be quite careful not to numb the nerve as well. But using the low-level laser, you can use the laser right here to inactivate the trigger point, and the nerve supply is intact, and you frequently get either immediate resolution of this strange type of nerve irritation that you might see, or a patient will notice a diminution of their symptom and a resolution of it the next day or two at home. The posterior tibialis, while its primary area is the Achilles tendon, and the trigger point actually usually is a little bit higher here, it can also entrap portions of the common peroneal nerve that are coming under the fibula here. These are where the gemellis are, and the obturator internus and the piriformis. These can all interfere with the course of the pudendal nerve. The entrapment of a twig of the radial nerve that innervates the lateral epicondyle by the supinator muscle in the forearm will give you the tennis elbow type symptoms, but frequently this symptom is more of a burning pain than the deep, severe aching that you get with the underlying tendinitis. But it's something to remember when you can't seem to get rid of the tennis elbow problem. As you can see, the olecranon is here. This is the lateral epicondyle right here. This extensor tendon is where the extensor of the digits combine and form one tendon, and you have the brachioradialis that attaches right here, which can also give you the tennis elbow problem. That's this one right here, and this is the supinator muscle that we talked about, which the normal trigger point, which can give you these. This looks like the brachioradialis results, or excuse me, the reference areas. But the best way to test for this trigger point is to see whether or not the muscle is really tight, and just evaluate the patient's ability to pronate their wrist while the examiner holds the elbow still. If this supinator is tight, pronation is significantly restricted. And again, there's a twig of the radial nerve that comes right through here, through that supinator muscle, and innervates area over here that was the electron area. Similar to carpal tunnel, there is a tarsal tunnel where the flexor retinaculum can be tight and irritate some of the nerves that go through it and innervate both the lateral and lower portions of the foot. And the abductor hallucis can be the primary muscle right here and can give you a not only pain here but a very tight muscle, and the nerves coming down through this area here can get entrapped. And carpal tunnel we've seen